My name is Lauren Johnson, and at 32, I thought I understood the rhythms of Shale Valley Hospital in Fossil Creek, North Dakota. As the night shift supervisor in our medical surgical unit, I'd grown accustomed to the quiet hum of monitors, the soft shuffle of nurses making rounds, and the occasional emergency that would send our small team into coordinated action. Fossil Creek wasn't exactly a medical metropolis. Our hospital served a community of 12,000, surrounded by wheat fields and oil rigs that dotted the horizon like mechanical prayers. Most nights we handled routine post-operative care, medication administration, and the occasional transfer from our emergency department. It was predictable work, the kind that let you build genuine relationships with your colleagues over years of shared shifts. That's why the small inconsistencies started bothering me more than they should have. It began with medication counts that didn't quite align. Nothing dramatic. A discrepancy of 1 or 2 pills in our controlled substance inventory that could easily be explained by documentation errors or timing issues between shifts. Our pharmacy director, Kenneth Martinez, mentioned it during our monthly unit meeting, his tone casual but his eyes lingering on our faces a beat too long. "Just want everyone to double-check their waste procedures," he'd said, adjusting his wire-rimmed glasses. "We're seeing some minor variances in the narcotic counts." The room had filled with the usual murmurs of acknowledgement. These things happened in hospitals. Human error was inevitable when you were dealing with dozens of medications across multiple patients every shift. But something in Kenneth's delivery made me pay closer attention to the details I'd previously overlooked. Then there were the computer access logs. As a supervisor, I reviewed them monthly as part of our quality assurance protocols. Most entries followed predictable patterns. Nurses accessing patient charts during their assigned shifts, physicians reviewing cases, pharmacy staff updating medication orders. But I started noticing unusual login times, brief sessions that occurred during shift changes when the system should have been relatively quiet. The timestamps bothered me. 2-minute sessions at 3:47 a.m. Quick logins during lunch breaks. Access patterns that didn't match the natural flow of patient care. I mentioned it to Dr. Catherine Williams, our unit medical director, during one of our weekly check-ins. She listened with the careful attention she brought to all administrative concerns, her fingers steepled as she considered my observations. "Could be staff catching up on documentation," she suggested. "You know how behind everyone gets during busy shifts." It was a reasonable explanation, but it didn't settle the growing in my chest. I'd been supervising long enough to recognize the difference between legitimate catch-up work and something else entirely. The breaking point came on a Tuesday night in October. I was reviewing the previous week's incident reports when I noticed a pattern I'd missed before. 3 separate patients had reported feeling confused about their medication schedules. Not dangerous confusion, nothing that compromised their care, but enough to generate documentation. Each patient mentioned a nurse who had asked detailed questions about their home medications, their pharmacy preferences, their insurance coverage for prescriptions. Questions that seemed thorough and professional in isolation, but formed a troubling picture when viewed together. The nurse they described was someone I trusted completely. Someone who had mentored me when I first arrived at Shale Valley 5 years ago. Someone whose dedication to patient care had never been questioned. As I sat in the dim glow of my computer screen, the hospital settling into its midnight quiet around me, I realized I was facing a possibility I didn't want to acknowledge. The small inconsistencies, the unusual access patterns, the patient reports, they were all pointing toward Anne that would shatter everything I thought I knew about my workplace. My hands trembled slightly as I pulled up the detailed access logs for the past month. The gene was there, hidden in plain sight among thousands of legitimate entries. A pattern of behavior that spoke to something far more serious than documentation errors or innocent curiosity. The silence of the hospital corridor suddenly felt oppressive, filled with questions I wasn't sure I was ready to answer. The nurse I suspected was Lauren Mitchell, my senior staff nurse, and the person who had shaped my understanding of what it meant to care for patients at Shale Valley Hospital. When I'd arrived fresh from nursing school 5 years ago, overwhelmed by the transition from textbook theory to real-world practice, Lauren had been my anchor. She was 43, with 15 years of experience that showed in every confident movement through the corridors. Lauren had taught me how to navigate the Epic system efficiently, how to prioritize when 3 call lights went off simultaneously, and how to maintain compassion during the longest shifts. Her patient advocacy was legendary among staff. She'd fought insurance companies over coverage denials and stayed late countless times to ensure proper care transitions. More importantly, Lauren managed our secure communication systems for patient information. She'd been instrumental in implementing our current privacy protocols and often led training sessions on HIPAA compliance. Her access credentials were among the highest in our unit, a privilege earned through years of demonstrated reliability. The thought that she might be misusing that trust felt like questioning gravity itself. I spent the next week observing more carefully, telling myself I was being paranoid while documenting everything I noticed. Lauren's behavior remained professionally impeccable during patient interactions. She was thorough, compassionate, and clinically excellent. But those late evening computer sessions continued, always when the unit was quieter, always lasting longer than typical documentation required. On Thursday evening, I decided to review the specific patient medication lists that had been accessed during those unusual timeframes. The system logs showed detailed timestamps for every entry, every screen viewed, every record opened. What I found made my stomach drop. Lauren had been systematically accessing patient medication profiles, but not in the pattern of someone providing direct care. She was viewing the prescription histories of patients she hadn't been assigned to, focusing specifically on pain management protocols, anxiety medications, and sleep aids. The access logs showed she was spending significant time reviewing insurance coverage details and pharmacy information for these same medications. Even more troubling, she was cross-referencing this information with patient demographic data, ages, addresses, insurance providers. The pattern suggested she was building profiles of patients who might be prescribed certain medications, patients whose information could be valuable to someone looking to understand prescription patterns in our community. I sat in my office until nearly midnight, cross-referencing the access logs with our patient assignment sheets. The haste was undeniable. Lauren was using her privileged access to gather information that had nothing to do with patient care and everything to do with personal interest in controlled substances. The realization hit me like ice water. She wasn't stealing medications directly that would have been caught by our inventory systems. Instead, she was harvesting patient data about prescription patterns, possibly to identify sources or understand local availability of specific drugs. It was a sophisticated violation that exploited her trusted position and deep knowledge of our systems. Friday morning brought a new development that confirmed my worst fears. Kenneth Morrison from our pharmacy called with a routine question about a prescription clarification, but his tone carried an edge of concern. "Kelly, I've had 3 patients this week ask about transferring their prescriptions to different pharmacies," he said. "They mentioned a nurse had suggested they might get better service elsewhere. Is there some issue with our usual pharmacy partners I should know about?" My heart raced. Which nurse made these suggestions? They didn't give names, but the descriptions sound like Lauren Mitchell. Is she having problems with one of our pharmacy relationships? I assured Kenneth I'd look into it, but internally, the pieces were falling into place with sickening clarity. Lauren wasn't just accessing patient medication information. She was actively engaging with patients about their pharmacy choices, potentially steering them toward specific locations or gathering intelligence about their prescription habits. That afternoon, I made a decision that felt like stepping off a cliff. I needed to document everything I'd discovered before confronting anyone, but I also needed a witness to my findings. The only person I trusted completely was Catherine Rodriguez, our charge nurse for the evening shift. Catherine had worked at Shale Valley for 8 years, building a reputation for uncompromising integrity and clinical excellence. She was known for her direct communication style and her refusal to tolerate anything that compromised patient care or safety. If anyone would understand the gravity of what I'd uncovered, it would be Catherine. I found her in the break room during shift change, reviewing the evening assignments with her characteristic attention to detail. Her dark hair was pulled back in a practical ponytail, and she looked up with the focused expression she wore when processing complex information. "Catherine, I need to show you something," I said, keeping my voice low. "It's about some unusual access patterns I've been tracking." She followed me to my office without question, settling into the chair across from my desk with the same serious attention she brought to patient care. As I walked her through the access logs, the medication profile patterns, and the pharmacy inquiries, I watched her expression shift from curiosity to concern to something approaching anger. "This is systematic," she said finally, her voice tight with controlled emotion. "She's not just accessing random information. She's building a database of patient prescription patterns." "That's what I'm seeing too," I confirmed. "The question is what she's doing with this information and how long it's been going on." Catherine leaned back in her chair, processing the implications. "Kelly, this isn't just a privacy violation. If she's using patient information to facilitate drug-seeking behavior or sharing prescription patterns with outside parties, we're looking at potential criminal activity." The weight of that statement settled between us like a physical presence. Lauren Mitchell, the nurse who had mentored me, who had taught me to prioritize patient dignity above all else, was potentially using her position to compromise the very people she was supposed to protect. "What's our next step?" Catherine asked, her tone indicating she was already committed to whatever action was necessary. "I need to gather more before we report this," I said. "But I also need to be careful not to tip her off. If she realizes we're watching, she could destroy or change her patterns." Over the weekend, Catherine and I developed a careful monitoring plan. We would track Lauren's access patterns more systematically, document any unusual patient interactions, and build a comprehensive case before involving hospital administration or external authorities. Monday brought the confirmation we'd been dreading. Lauren accessed the medication profiles of 6 patients during her shift, none of whom were under her direct care. More significantly, she spent nearly 20 minutes reviewing the prescription history of a patient who had been discharged 3 days earlier, a clear violation of our access policies. When I reviewed the specific medication she'd been researching, the pattern became even more disturbing. She was focusing on patients prescribed high-value controlled substances, extended-release opioids, benzodiazepines, and stimulant medications. The insurance and pharmacy information she was accessing would provide a complete picture of how these patients obtained and managed their prescriptions. Tuesday evening, Catherine witnessed Lauren engaging in an extended conversation with a patient about their home medication management. While the interaction appeared professional on the surface, Catherine noted that Lauren asked detailed questions about the patient's pharmacy preferences, their insurance coverage for prescriptions, and their experience with different medication formulations. "She's gathering intelligence," Catherine reported to me after her shift. "The questions were too specific, too focused on information that doesn't impact immediate care." That night, I made the decision to access Lauren's complete system activity for the past 6 months. What I found exceeded my worst expectations. She had systematically accessed the medication profiles of over 200 patients, building what amounted to a comprehensive database of prescription patterns in our community. The was overwhelming, undeniable, and heartbreaking. The person who had taught me to protect patient privacy was systematically violating it on a scale that suggested months or possibly years of deliberate misconduct. As I sat in my office, surrounded by printouts of access logs and violation documentation, I realized that tomorrow would bring the most difficult conversation of my professional life. The mentor who had shaped my understanding of nursing ethics had betrayed everything she'd taught me to value. The silence of the hospital around me felt heavy with the weight of broken trust and the knowledge that nothing would ever be the same. Wednesday morning arrived with the weight of inevitability. I had scheduled a meeting with Lauren for 7 a.m. before the day shift began in earnest. The documentation sat in a sealed envelope on my desk. 6 months of access violations, patient privacy breaches, and systematic misconduct that painted a picture I still struggled to accept. Lauren entered my office with her usual confident stride, coffee in hand, and that familiar smile that had once made me feel like I belonged in this profession. She settled into the chair across from my desk, completely unaware that her world was about to collapse. "You wanted to see me early today?" she asked, checking her watch. "I hope everything's okay with the new protocols we've been implementing." The irony of her words wasn't lost on me. I opened the envelope and placed the first page of access logs in front of her. "Lauren, we need to discuss some concerning patterns in your system usage." Her expression shifted almost imperceptibly, a slight tightening around her eyes. A barely noticeable pause before she leaned to examine the document. Years of working together had taught me to read her subtle reactions, and I watched as she processed what she was seeing. "I'm not sure I understand," she said carefully. "These are just routine patient lookups. I placed the second page down, then the third. The pattern became undeniable. Hundreds of medication profile accesses for patients not under her direct care. Concentrated searches for controlled substances. Systematic documentation of pharmacy and insurance information. Lauren, you accessed the medication profiles of 237 patients over the past 6 months. Patients who were never assigned to your care, never admitted to your unit, and in many cases never even hospitalized during your shifts. The silence stretched between us like a chasm. I watched her calculate, weighing her options, deciding how much to admit or deny. A woman who had taught me about integrity was now demonstrating its complete absence. You don't understand the complexity of what I do here, she finally said, her voice taking on a defensive edge. Patient care coordination requires comprehensive understanding of medication management across the entire facility. Patient care coordination doesn't require accessing insurance billing codes for controlled substances, I replied, placing another page up before her. It doesn't require documenting pharmacy preferences for patients you've never met. Her composure began to crack. The confident mentor I had admired was being replaced by someone I didn't recognize. Someone cornered and desperate. Kelly, you're making assumptions about information you don't fully comprehend. My responsibilities here extend beyond what you see on a daily basis. Then, explain it to me, I said, keeping my voice steady despite the turmoil inside. Explain why you need to know which patients receive extended-release opioids through which pharmacies. Explain why you're documenting insurance coverage patterns for benzodiazepines. She stood abruptly, pacing to the window that overlooked the parking lot. When she turned back, her expression had hardened into something I'd never seen before. Cold calculation, mixed with barely contained anger. You have no idea what it's like to work in this system for 20 years, she said. To watch administrators make decisions that compromise patient care while they collect bonuses. To see resources wasted while we're expected to do more with less. So you decided to compromise patient privacy instead? I decided to ensure that information reaches people who can actually help these patients manage their medications effectively, she snapped. There are networks of support that exist outside these sterile hospital walls. The admission hung in the air between us. She had essentially confessed to sharing patient information with external parties, though she was still trying to frame it as some form of advocacy rather than the violation it clearly represented. Lauren, you've accessed confidential patient information without authorization and shared it with unauthorized individuals. That's not patient advocacy. That's a federal crime. Her laugh was bitter, devoid of any warmth I'd ever associated with her. You think you understand this industry, Kelly? You think your textbook ethics apply to the real world of healthcare? I think patient privacy laws exist for a reason, I replied. And I think the person who taught me to respect those laws should understand their importance better than anyone. She returned to her chair, but her posture had changed completely. Gone was the supportive mentor. In her place sat someone who viewed me as an obstacle rather than a colleague. What do you want? She asked bluntly. I want you to explain how long this has been going on, who you've been sharing information with, and what you've done with the data you've collected. And if I refuse, then I'll be filing a formal report with administration and the state health department this afternoon. The threat landed with visible impact. Lauren's face went pale, and for the first time since I'd known her, she looked genuinely frightened. You don't understand what you're doing, she said quietly. There are people who depend on the information I provide. Patients who need help navigating a system that's designed to confuse and exploit them. Then help me understand, I said. Tell me who these people are and how this information helps them. She was quiet for a long moment, staring at her hands. When she looked up, there was something almost pleading in her expression. There are support groups, she said slowly. People who help patients find affordable medications, who connect them with resources when insurance fails them. The information I gather helps identify patients who might benefit from these services. Unauthorized support groups accessing confidential medical information? Community advocates, she corrected. People who actually care about patient outcomes rather than billing cycles. The rationalization was elaborate, but it didn't change the fundamental violation. She had systematically breached patient privacy, potentially exposing hundreds of people to identity theft, insurance fraud, or worse. Lauren, regardless of your intentions, what you've done is illegal. You violated HIPAA, compromised patient confidentiality, and potentially exposed our hospital to massive liability. So what happens now? She asked, her voice barely above a whisper. Now you're going to provide me with a complete list of everyone you've shared information with, every patient whose data has been compromised, and every instance of unauthorized access over the past 2 years. 2 years? I have reason to believe this pattern extends beyond the 6 months I've documented. She closed her eyes, and I could see her making calculations, weighing the consequences of cooperation against the risks of continued denial. And if I provide this information, then I'll recommend that administration handle this internally, before involving external authorities. But Lauren, this ends today. Completely. The woman who had once been my most trusted colleague sat across from me, transformed into someone I barely recognized. The betrayal cut deeper than any professional misconduct. It was personal, devastating, and complete. I need time to compile the information you're requesting, she said finally. You have until 5 p.m. today. After that, I file the formal report regardless. She nodded slowly, gathered herself, and stood to leave. At the door, she paused and looked back. Kelly, I hope someday you'll understand that good intentions sometimes require difficult choices. I understand that patient trust is sacred, I replied, and that betraying it is never justified, regardless of intentions. After she left, I sat alone in my office, surrounded by systematic betrayal by someone I had trusted completely. The silence felt different now, not peaceful, but heavy, with the weight of broken relationships and shattered trust. Catherine knocked on my door an hour later, her expression concerned. How did it go? She asked. She admitted to sharing patient information with unauthorized external parties, I said. She's claiming it's for patient advocacy, but the violations are extensive and systematic. Catherine sat down heavily. What happens next? She has until 5 p.m. to provide a complete disclosure of her activities. Then we involve administration and likely external authorities. Are you okay? Catherine asked gently. I looked at the spread across my desk. Hundreds of privacy violations committed by someone who had taught me to value patient confidentiality above all else. I will be, I said. But right now, I need to prepare for the most difficult afternoon of my career. The morning shift was beginning around us, nurses and staff starting their day with the assumption that their colleagues could be trusted. By evening, that assumption would be shattered, and nothing at Shale Valley Hospital would ever be quite the same.